accompanied by sometimes sneezing, hyposmia and anosmia, additional signs and symptoms. The common respiratory tract bacteria which are involved in it is Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis. Rhinosinusitis cough may be present for, say, most can be present whole day, but most commonly it is the early morning. Reaction to the accumulated secretions in the nasopharynx during the whole night, and when you wake up, it dislodge and you have to cough it out. Okay. Viral and bacterial rhinosinusitis differential. How you differentiate diagnosis with viral and bacterial? It's not a very easy task. I know sometimes you give the benefit of doubt to the patient and start bacterial infection, start treating bacterial infection. But common features, viral and bacterial. See, duration of symptom is usually viral 7 to 10 days. Bacterial rhinosinusitis is more than 10 days. But sometimes if you find that the symptoms are worsening by day, or patient is becoming all right, then it started worsening, then bacterial infection is occurring. Fever more than 102 in bacterial, less than 102 in viral. Urinary nasal discharge, viral no, bacterial yes. Facial yes, no, number symptoms onset for initial treatment, yes. Bacterial, new onset of symptoms may be present. Okay. Now, this is the management for sinusitis. The respiratory tract infection, same is true. These are the NICE guidelines, National Institute of Healthcare Excellence. It is a body in UK and started this thing in about 1991. And they recommend the first choice of drug is penicillin, methylpenicillin, but we usually ampicillin. Age-wise dose, everybody knows. Second choice, if the first cannot be given, age-wise dose of co-amoxicillin. Co-amoxicillin is potentiated in amoxicillin. Alternative, if there is a penicillin allergy or penicillin intolerance or penicillin resistance, then clarithromycin is the best medicine. Other one is doxycycline, but doxycycline cannot be used below 12 years, so we have to go for clarithromycin. So one thing that you should note is that the cefixime is not recommended here. For upper respiratory tract infection, cefixime is not ideal medicine. It does work sometimes, no doubt about it. But percentage-wise, clarithromycin is best better response to my time. Hot topic of today: differential diagnosis in current COVID-19 outbreak. Okay. Coronavirus disease, everybody knows it's a big burden now, and I'm sitting in the home, so I'm without my mask, otherwise everybody will be masked. Okay. Coronavirus, you will find the history of traveling aboard or some contact with an infected person in the last 14 days. Sinus symptoms are similar to the other conditions, upper respiratory tract. PCR test usually settles the case. Sometimes antibody tests are also required to see whether you are getting immune or not. Second is hay fever. It is an allergic type of rhinitis. Usually it has long history. Every time it's flowering weather, you get it. Every time dusty weather, you get it. Every time rainy weather, you get it. It's this presentation. So usually the father and mother and patient himself are going, most of the time knows that he is a hay fever. अब मैं ये खाता हूँ तो मुझे हमेशा ये प्रॉब्लम होती है. एलर्जी इन स्किन टेस्ट एंड आईजी टेस्ट कर सकते हैं. Now chronic sinusitis. Chronic sinusitis usually lasts for more than 6 weeks. It's chronic form. Sinusitis is a very enclosed space, so it takes very long to remove it. Sometimes you have to dig it out. Radiological studies, X-ray, will reveal that there is a fluid in it. So clinical characteristics: hyposmia, anosmia, chronic inflammation, bacterial infection, bacterial infection. CT scan of sinusitis or X-ray will reveal it. Acute sinusitis. Acute is often due to an infectious cause. Usually clinical diagnosis. This is acute sinusitis can be mainly clinical diagnosis. Facial tenderness, sometimes pain on percussion in frontal and maxillary sinuses, but it's dental pain and failure of protypical or oral detection. If you concomitant dental pain or give it some medicine to relieve and don't relieve, then you consider sinusitis. Okay. Now the streptococcal tonsillitis. Now this is a very common thing in children because of our eating habits in children. There is one score system, McIsaac score system. It can help in discriminate the score. You can see the what is the score and you can detect what is the cause of it. Second is throat swab. You can see whether it's system cup or not. You can find tender anterior cervical gland, tonsillar swelling, exudate on tonsils, absence of cough, temperatures greater than 100. Okay. The positive throat culture will definitely settle the diagnosis. Now this is the acute otitis media. It is a very common presentation in our OPDs. Patient comes with a pulmonary discharge from ears, and this can occur in children more often than in adults because of the ejection tube, which is straighter and shorter and broader in children. That's why they suffer more from acute otitis media, and it is usually bacterial. Consequences are hearing and associated symptoms that in some cases may affect behavior and language development. If you can't hear properly, behavioral changes and language development will be affected. 5% of children are prone to otitis media. Now, this is very interesting fact that few children are prone to otitis media. I'll come to you why. Prone to otitis media children who are labeled who have 3 episodes of otitis media in 6 months or 4 in 12 months. They are labeled as prone. The most common bacterial associated with acute otitis media is Staph pneumonia, Haemophilus influenza, Morixella catalyst, group A streptococci. Peak incidence is at 12 years of age. Acute otitis media. Now we come why there some people are prone to, why they are labeled prone. The risk of developing episode within 1 month after the onset of primary infection is estimated 35% of otitis media when you treat them, they relapse. And in majority of these cases, the relapse case 75% cases of them, the bacteria from culture will be different. That suggests that underlying susceptibility to current acute otitis media. 25% same bacteria or treatment failure. They recur. Level as chronic acute otitis. Okay. Current management, same nice guidelines. Acute otitis media, dose of antipyretics, usually paracetamol, ibuprofen, or anything that relieves pain and fever. First choice is again amoxicillin. If there is penicillin allergy or you cannot give penicillin, then clarithromycin or erythromycin. Bacteria or under 2 years infection both is no backup or immediate antibiotic. If both years of infection, you either not give antibiotic or just give it antibiotic as a backup. If the symptom does not subside, then you can give antibiotic. There are other symptoms also, sometimes unwell, very great fever, very great pain, then you give immediate antibiotic. That is a clinical judgment. If penicillin or erythromycin, you are giving them and the symptom worsens, then you can, second choice is fluoxetine. Now, pharyngitis and tonsillitis. The another part of upper respiratory tract infection. Sore throat pharyngitis represents about 5% of all outpatient primary cases visit for pediatric population. 5% of all patients that we visit to are pharyngitis and tonsillitis, not upper respiratory, only pharyngitis. Viral pharyngitis is typically self-limiting, minimal sequelae. Bacterial fungal infections are more severe. So usually, upper respiratory tract infections are viral. The most concerning are strep pyogenes infection, which can lead to suppurative and non-suppurative complications. Strep pyogenes group A streptococcus infection, sore throat, occur up to 30% of sore throats include pediatric. Diagnosis of cause of pharyngitis is primarily achieved using key clinical features seen in the modified centaur or fever pain scoring system. This is also a same system, just like my Tyson. There is a fever, 1 point pain, 1 point similar point. You score them and give them antibiotic or not. Okay. Other thing is rapid antigen detection testing system can be pharyngitis. The common organism causing pharyngitis, viral, bacterial, sometimes fungus, candida, fungus. Virus for rhinovirus, adenovirus, Coxsackie virus, coronavirus, respiratory syncytial virus. Bacterial mesh tract, Haemophilus influenza, chlamydia, mycoplasma, Neisseria, Treponema, mainly system and Haemophilus and chlamydia. Okay. Now, pharyngitis and tonsillitis. Meningitis of pharyngitis focuses on deciding whether to watch or wait, whether to give them treatment or initiate antibiotic therapy. Now, this is the decision time where you have to decide whether you give antibiotic or just symptomatic treatment. Your clinical judgment, your examination, it will decide. You can try to do for swab and culture, but sometimes it takes very long period to culture to come up. So in that case, you have to decide whether to give antibiotic or not, because later period can be very dangerous. Now, there is a chart here. It shows three things: viral, bacterial, and fungal infection. You can see viral shows only pharyngeal redness and erythema tonsil. Bacterial shows palatal petechia, exudate tonsillar hypertrophy. Fungal shows stomatitis, chelosis, and cut-like plaques on tongue. This is the distributive feature of pharyngitis. Either it is viral, it is bacterial, or it is fungal. And current management, again, nice guidelines: penicillin, clarithromycin, erythromycin. The first choice is penicillin. Penicillin used in our OPDs and this has been very restricted because of the dosage. It has to be given 6 hourly, which is very difficult sometimes for babies to give, and because of its side effect. Clarithromycin is better choice. Third is erythromycin. Erythromycin again has to be given 3-4 times a day. Studies for management of options in upper respiratory tract. As I said, clarithromycin is very effective against wide range of viral organisms, including gram-positive cocci, Haemophilus influenza, Moraxilla catarrhalis, Mycoplasma, chlamydia, Mycobacteria, Lutein encephalitis, protozoan nodules also. It is a good half-life. Clarithromycin is a very good half-life, so it can be given in BD dose, which is more tolerable for children and especially families. It is concentrated in cells and tissues. The response is very good, including tonsils, nasal mucosa, middle air fluid, lung. Its response is very good. It appears to be safe and generally well tolerated. Efficacy and safety of fluoromycin, clarithromycin in pediatric patients with upper respiratory tract. 24 studies were done in different studies. 24 studies. Rescue was certainly equal to other antibiotic studies with respect to clinical cure, clinical success, the relaxation was associated with the better bacteriological adaptation. And comparing to other antibiotics, its eradication was better and lower risk of related adverse events. Yes. Conclusion is that high quality evidence shows the clarithromycin is safe and effective alternative for treatment of upper respiratory tract infections in pediatric patients. It's superior to other antibiotics. Clarithromycin has only one problem. It's taste sometimes because it's not present in syrup form. It's present in granular form. Each granule is coated so give it to better taste and better tolerability. Only thing that you have to teach the family of the patient is that don't shake it very vigorously, otherwise the granules will break up and its taste will be unmasked, which will be very bitter. Now we come to lower respiratory tract infections. Okay, upper respiratory tract infections we have dealt most of it. Basic and the advancement in diagnosis of bacterial lower respiratory tract. How to differentiate bacterial viral lower respiratory tract point of care. The respiratory tract is whole one structure. Sometimes overlapping of things and sometimes infection spread from one place to another. And it's very difficult to label it as very bronchitis or bronchiolitis. There's many overlapping things. Now, antibiotic treat a lower respiratory tract with bacterial etiology. Okay, no problem. Antibiotic resistant bacteria as well as sequela from the use of unnecessary antibiotics include Clostridium deficient infection. Defining the etiology of spread is imperative for appropriate patient. You have to be very careful. The lower respiratory tract infections have more morbidity and more mortality. You have to be careful and treat the patient as per what he needs. The diagnosis C-reactive protein is a very common test now, and acute fluid reactions sensitize the liver in response to cytokines such as interleukin 6 released by macrophages and antipocytes in response to inflammatory conditions from bacteria. It can be used as a marker and to see whether infections are occurring or not. Now, C-reactive protein levels less than or equal to 20 indicate a self-limiting lower respiratory. If it is more than 100, it does need antibiotics. Beware that clinical judgment is much better. The C-reactive protein will take 1 day to come, and you have to treat the patient on this spot. So, benefit allowed should be given to patient. If you feel like a patient is toxic and symptoms of very prolonged period, then you have to go back. Another marker is procalcitonin. It is similar to C-reactive protein and it increases with the infection, decreases. Now, the major chunk of lower respiratory tract infection is pneumonia. Pneumonia, everybody knows, clinically diagnosed and can be appropriately diagnosed with a single X-ray, which can be better. You can see in the OPD and diagnose it very easily. Pneumonia is a form of acute respiratory tract infection that affects the lungs, the inflammation lung, parenchyma. Small sacs lungs are made of alveoli. They fill with air with healthy person breathes in and out. When an individual has a pneumonia, the alveoli are filled with pus and fluid which makes breathing painful and limits oxygen intake. Coming and outgoing of oxygen carbon dioxide limited. Single largest infectious cause of death in children worldwide. Worldwide, single largest infectious cause of death. 50% of all deaths in children under 5 years. It's a major chunk. Local research is usually considered in the investigation of predictive signs of pneumonia is ready, but statistically it can be confirmed in part. The causes of pneumonia. Pneumonia is caused by a number of infection agents. Sometimes viruses, sometimes bacteria, sometimes fungi, staph pneumonia, immunofluenza, respiratory syncytial virus, pneumocystis. They can all cause pneumonia. Okay. Now, antibiotic choice, again the NICE guidelines. Now, these NICE guidelines are for the community acquired pneumonia. This is community acquired pneumonia. Patients come to you with pneumonia from environment or wherever he is. Again, we same treatment, amoxicillin, alternative antibiotic, clarithromycin, erythromycin, doxycycline, as I told you, cannot be used below 12 years. It's limited what it has with it. Okay. Now, this is the antibiotic choice. Okay, but this is for hospital acquired pneumonia. The hospital acquired pneumonia, sometimes we label them as uh, children with low immunity. They suffer from it. They come repeatedly to hospital. They have repeated admissions. They have no effect. First choice for amoxicillin, alternate clarithromycin. Dosage are, you have to. It is given in the front, but everybody knows it, so I'm not going into the detail. Again, the choice is between pneumonia for treatment of pneumonia is amoxicillin and clarithromycin. Now, lower respiratory tract infections include bronchiolitis and bronchitis. Viral fever, bronchiolitis is usually viral. Characterized by inflammation of bronchial. Contagious infection of lower respiratory tract infection is high during the winter season when it is cold and blood circulation is less on this area. The Sinusitis of bronchiolitis involves a combination of airway edema, increased mucus production, and necrosis of airway epithelial cells due to direct cytotoxic. Key pathogens include viral respiratory syncytial, coronavirus, adenovirus, and rhinovirus. Now, bronchitis. Acute bronchitis is defined as a self-limiting lower respiratory tract infection to distinguish this condition with common cold. You have to distinguish. To distinguish this condition from common cold and other respiratory bronchitis refers specifically to the infection causing inflammation in the bronchial areas, whereas pneumonia denotes infection in the lung parenchyma, in the consolidation resulting in consolidation of the affected tract. Pneumonia, lung parenchyma, it always involves bronchitis, was only bronchial areas, inflammation of the bronchial airways. Okay. The symptoms of acute bronchitis are due to acute inflammation of the bronchial wall, which causes increased mucus production along with edema of bronchus. Productive cough, which is the hallmark of low respiratory tract infection. Whenever there is low respiratory tract infection, the productive cough will be there, mucus will be there, and it will be productive cough. And it takes sometimes very long period to eradicate that cough. Pulmonary function studies of patients with acute bronchitis demonstrate bronchial obstruction similar to death in asthma. As the symptoms of acute bronchitis abate, pulmonary function returns to normal. This is a very good sign that as soon as the bronchitis abates, the pulmonary function becomes normal. Continuing with the bronchitis, cough is typically worse at the night or after exercise because you need more oxygen and it becomes more painful. Lasts more than 2 weeks. Now, note this thing: the cough lasts for more than 2 weeks. Usually, the attitude of patient and the family is that you give the medicine and everything will settle. Cough lasts for more than 2 weeks. More than 2 weeks in half the patient, in some patients, 4 weeks. The severity decreases on, but it remains. The cough remains. The diagnosis of bronchitis is primarily clinical. Acute cough, the other causes, pneumonia, asthma, post-nasal drip should be ruled out. Infection, pathogen, usually those things, chlamydia, pneumonia, and microphysician. Treatment is aimed at symptom reduction until infection is resolved and bronchial damage repaired. As I told you, they repaired by themselves, and if the pulmonary function does well, it will take time. Antibiotics are not recommended in the majority of patients. Now, bronchitis are usually viral as they don't need antibiotics unless symptoms remain for a very prolonged period or patient shows aggravation of signs. Complications are rare. Most bronchitis syndrome, which can produce a cough lasting for several, sometimes they still occurs. Now, bronchiolitis is pediatric current malignant. Then supportive care, bronchitis, dehydration करेक्ट करनी होती है आपको, बिल्कुल फ्लूइड ज़्यादा भरना होता है, निकल ज़्यादा रहता है, इनपुट कम होता है. Sometimes myalgia, fatigue, you have to give the symptomatic treatment and correct the dehydration. If you feel it is a secondary infection, clinical judgment, prolongation of the symptoms, then you have to do antibiotic.